That increased understanding and the ability to follow our patients over long periods of time has allowed us to evolve the philosophy of modern day thyroid cancer surgery practice. If you go back into history, as the previous speaker mentioned, in 1848, Samuel D. Gross, the professor of surgery at Jefferson Hospital in Philadelphia, called thyroid surgery as horrid butchery. And from there, we have come to clearly precision surgery with nearly 100% cure in a great majority of patients and with no aesthetic or functional outcomes, leaving the patient with any disability. So this is what Samuel Gross said in 1848. And I want to read this because it's important for the audience to listen to this. Uh, can the thyroid in the state of enlargement be removed? Question mark. Emphatically, experience answers no. Should the surgeon be so foolhardy to undertake it, every stroke of the knife will be followed by a torrent of blood, and lucky it would be for him if his victim lived long enough for him to finish his horrid butchery. No honest and sensible surgeon would ever engage in it. And the operative mortality around that time was 40% for any thyroid operation. We have come a long way from there. Uh, Thanks to the trailblazers, Billroth, Coker, Klein, Mayo, Hartley, Dunhill, and others who brought operative mortality down to 1% and made thyroid surgery safe. Even 1% is a high mortality in today's practice. Mortality to thyroid surgery should be in the 0.0005% or less. Theodore Coker received even a Nobel Prize for bringing thyroid surgery into reality in 1909 based on his 5,000 cases of thyroid operations that he had done. Over the years, anesthesia, antisepsis, blood transfusion, and antibiotics entered into the arena and made surgery safer. Today, we have improved understanding of the pathobiology of thyroid cancer, and developments in physiology, biochemistry, imaging, and technology has allowed us to practice precision surgery for thyroid cancer, which is safe, effective, and curative. So, what are the myths and misconceptions? If you were to ask in the community around the world, surgical community, how do you treat thyroid cancer? The answers would be as follows. All patients with thyroid cancer need subtotal or near total thyroidectomy. All patients need postoperative radioactive iodine ablation. Postoperative TSH should be brought down to zero, and patients should be followed up with annual radioactive iodine scans, whole body scans. None of these are valid statements today and are truly archaic and belong in the pages of history. What I will share with you is data throwing each of these myths and misconceptions out of the window. So the first myth is, and even the endocrinologists in the United States believed until 2009 that T1 cancer should be subdivided into T1A less than 1 centimeter, the so-called microcarcinomas, and T1B 1 to 2 centimeters, because there was a huge difference in their biological behavior. Even the American Thyroid Association guidelines in 2009 recommended total thyroidectomy for all tumors over 1 centimeter. And they considered the possibility of a lobectomy for tumors less than a centimeter, so-called microcarcinomas. Where did this philosophy come from? There was no data to support it. We provided the data and showed that for T1A and T1B, the 10-year disease-specific survivorship is exactly the same for T1A and T1B. In fact, there was zero deaths in patients with T1A and T1B tumors. So the myth of the need for total thyroidectomy over 1 centimeter is gone. And that reflected into the revision of the American Thyroid Association guidelines in 2015, where now they recommend lobectomy for intrathyroidal tumors up to 4 centimeters, not only T1, but T2 tumors. If they are intrathyroidal, lobectomy is sufficient. Another myth is that the size of the intrathyroidal primary impacted on outcome. We just touched upon that. The 10-year survival for all intrathyroidal tumors, regardless of their size, is 100%. This is cause-specific survival. Nobody dies from thyroid cancer if they have a differentiated intrathyroidal primary tumor. It is only the large tumors over 4 centimeters, or more importantly, where there is gross extrathyroid extension, that we see progressive mortality over the years. And this is where we need to be surgically aggressive. So the squabbling about 1 centimeter, 2 centimeter, 3 centimeter tumors, which are all intrathyroidal, is truly unjustified. Not only our own data, but the national data from the American College of Surgeons of over 61,000 patients followed for 16 years. The survivorship between tumors 1 to 2 centimeters and 2 to 4 centimeters is more or less comparable. So the myth of doing a bigger operation unnecessarily for intrathyroidal tumors up to 4 centimeters is no longer justified. Another myth is that all patients with papillary carcinoma need a total thyroidectomy. And that is not quite true. Even the previous speaker mentioned that the complications for unjustified total thyroidectomy are unacceptable. Recurrent nerve injury, hypoparathyroidism, and accessory trauma to the patient, in addition to which the patients will be punished to taking lifelong thyroid medication. So we provided the data from our large database of 884 consecutive patients, matched pair analysis, having all of them intrathyroidal tumors. All patients were N0 and M0, and all had differentiated carcinoma. 41% had undergone lobectomy, and 59% had undergone total thyroidectomy. The 5 parameters of outcome: local recurrence-free survival, neck recurrence-free survival, distant recurrence-free survival, disease-specific survival, and overall survival were exactly the same. No statistically significant difference. This culminated again into the change of the ATA guidelines, recommending now lobectomy for all intrathyroidal tumors which are unilateral up to 4 centimeters. And the national data of over 62,000 patients, again, parallel what we showed. Lobectomy versus total thyroidectomy, 16-year follow-up, 61,700 patients, exactly superimposable lines. So there is no rationale or basis for unnecessarily unindicated total thyroidectomies. Another myth is that a multifocal papillary carcinomas are more aggressive compared to unifocal tumors. Not quite true. The 10-year survivorship for recurrence-free survival between unifocal disease, shown in blue, and multifocal disease, shown in green, is exactly the same. So multifocality is the nature of the tumor. It does not impact upon biological behavior of the cancer. And the 5 parameters I showed you before of measures of outcome: local recurrence, regional recurrence, distant metastasis, disease-specific, and overall survival were exactly the same for unifocal versus multifocal tumors. Another myth was that if you do a lobectomy and final pathology report comes back with a positive margin or microscopic extrathyroid extension or microscopically positive margin, the knee-jerk reaction is take the patient back to the operating room, do completion thyroidectomy, and give radioactive iodine. There was no basis or no data to promulgate that philosophy. So if you look at the survival on patients who had no extrathyroid extension, shown in green, and microscopic extrathyroid extension, also shown in green, are exactly the same at 10 years. This is disease-specific survival for negative margins or microscopic positive margins after a lobectomy. It is only when there is gross extrathyroid extension or macroscopic extrathyroid extension that the survivorship drops. So microscopic positive margin on a lobectomy specimen is not a trigger or not an alarm for overaction. Based on this data, the American Joint Committee removed microscopic extrathyroid extension from upstaging the tumor. It has been taken out from the staging system. Microscopic is no longer staged. It is only gross extrathyroid extension which would upstage the tumor. And if the extrathyroid extension grossly is anterior, involving the strap muscles, it would be called T3B. And any posterior gross extension to involve trachea, larynx, esophagus would be called a T4A tumor. So when do we do lobectomy? Lobectomy is indicated for unifocal, unilateral tumors in one lobe of the thyroid gland. Whether the tumor is small or large makes no difference. Whether the tumor is unifocal or multifocal makes no difference. As long as the opposite lobe is normal and the ipsilateral tumor is intrathyroidal, the size or multifocality makes no difference. We would consider total thyroidectomy only when there is gross extrathyroid extension, bilateral tumor involvement, where you have gross tumor nodules involving both thyroid lobes. Bilateral nodularity, you have cancer on one side, but a multinodular goiter on the other side, a abnormal thyroid lobe, we would consider total thyroidectomy. And those patients with extensive lymph node metastasis, where there is the need for radioactive iodine treatment, we would consider total thyroidectomy. What matters in thyroid cancer management is not what we as surgeons do in the operating room, but what the tumor and the patient tells us, which are called the prognostic factors, which are based on patient characteristics and tumor characteristics. They have been in vogue for nearly 40 years now. Initially from a paper by Ian Hay from Mayo Clinic in 1986. Similar data was presented from the Leahy Clinic, from Karolinska, and from our own institution, identifying independent factors impacting upon outcome and prognosis. Each of these factors are independently statistically significant. Surprisingly, all of these factors in each of these separate data sets are the same. Patient's age, histological grade of the tumor, gross extrathyroid extension, tumor size, and presence of distant metastasis. And all of these independent data sets identified these factors to be the same. Based on these prognostic factors related to the patient and the tumor, we can now risk stratify the patients. Young patients, and the age cutoff now is 55 years, not 45 years. Patients under 55, generally females with small tumors less than 4 centimeters, which are intraglandular with well-differentiated histology and no distant metastasis, fall into the low-risk category. In contrast, older patients, generally men with large tumors, with gross extrathyroid extension, or poorly differentiated histology, or presence of distant metastasis, fall into the high-risk category. And then you have older patients with good tumors and younger patients with bad tumors fall into the intermediate risk group category. Remember, in this risk group stratification, treatment is no longer present, even in the prognostic factors. Surgery, radioactive iodine, the extent of surgery is not even a prognostic factor. So look at the 10-year outcomes. At 10 years, in the low risk group, shown in green line, disease-specific survival is 100%. You cannot make it better. Even in the intermediate risk group, the survivorship is almost 99%. And it is only in the high risk group that you see progressive mortality as time goes on. So if we have to spend time, energy, resources, then we should be doing that to improve outcomes in patients who fall into the high risk category. Now, another myth is that everybody who undergoes thyroidectomy should get radioactive iodine ablation. Not quite true. Even the American Thyroid Association does not recommend radioactive iodine treatment in the low and intermediate risk group patients because there is no body of evidence that it improves survival. Is there any evidence in low risk? No. T1A, no. T1 and B and T2, no evidence. T3 tumors, no evidence that radioactive iodine does anything. Even in patients with nodal metastasis in the central compartment, there is no body of evidence that says radioactive iodine gives benefit. And even patients with lateral neck metastasis, where all disease has been removed and patient has no measurable thyroglobulin, there is no evidence that radioactive iodine does anything. It is only in the T4, meaning patient with gross extrathyroid extension or those with distant metastasis, that there is an indication for radioactive iodine treatment. And finally, this was mentioned earlier, that every thyroid cancer needs to be operated upon. Not quite true. I think the Japanese study by Ito and Miyauchi were mentioned. And based on their work, we have started an active surveillance program at our own institution for the past 10 years. We now have over 600 patients being on active surveillance, all intrathyroidal tumors up to 2 centimeters are under active surveillance. Only 8% of the 600 some patients required surgery because of growth in the size of the tumor by 1 to 2 millimeters. Rest of the 90% of the patients have remained stable on active surveillance. So American Thyroid Association guidelines have again changed, and they accept that an active surveillance management approach can be considered as an alternative to immediate surgery in patients with very low-risk tumors. So this is a fact of life. What you need is a patient who understands the biology of the disease, which requires us to explain to them. And if the patient and the physician treating the patient are on the same page, patients with small, low-risk tumors can be safely kept under surveillance. So in summary, thyroid surgery fundamentals, thyroid cancer is primarily a surgical disease. Surgery is the most effective and curative treatment for locoregional disease. Proper surgery is crucial for achieving cure and to minimize the risk of local recurrence. All adjuvant treatments are after complete surgery. Adjuvant treatments do not make up for inadequate or incomplete surgery. And incomplete surgery is truly precision surgery. And precision surgery is defined as a surgical procedure undertaken after thorough understanding of the pathobiology of cancer, selecting the right operation based on tumor and patient factors, and risk group stratification to minimize morbidity, complications, and sequelae of the operation while maintaining the highest degree of efficacy for cure and avoiding unindicated bigger operations and unnecessary adjuvant treatments. So, in a sense, all thyroid operations must be extracapsular. It can be extracapsular lobectomy or extracapsular total thyroidectomy. No thyroid tissue should remain at the site of surgery, such that patient's postoperative thyroglobulin is not measurable after a well-done total thyroidectomy. Pay special attention to the upper pole. People have a habit of putting a right angle clamp at the upper pole and tie it off. Do not do that. Tie the vessels, superior thyroid artery and its branches outside of the capsule of the thyroid gland. Pay special attention to the pyramidal lobe, where you are likely to leave thyroid tissue behind. And in the region of the cricothyroid membrane, be meticulous to identify the nerve, preserve it, and take every bit of thyroid tissue in the TE groove and at the Berry's ligament so as not to leave any thyroid tissue behind. Understanding the biology of thyroid cancer, appreciating prognostic factors, and employing risk group stratification is crucial for cost-effective treatment. So here is the tumor progression model, as I mentioned earlier. All thyroid cancers start in the thyroid follicular cell. They may differentiate into papillary or follicular. Nearly 85% present to you with that diagnosis. About 10 to 15% go further along the progression model and come to you with a tall cell or a poorly differentiated carcinoma. And rarely they progress on to present as an anaplastic carcinoma. Now, as this tumor progression is taking place from differentiated to poorly differentiated to anaplastic, there are clinical features which will tell you that the tumor is biologically progressing. Tumor size gets bigger, extrathyroid extension becomes manifest, and mortality increases. So what evidence do we have that such tumor progression occurs in real life? Well, all thyroid cancers are heterogeneous. If we take, for example, a patient with poorly differentiated carcinoma and look at the slides of his tumor, you will find there is heterogeneity in the histomorphology with areas of well-differentiated carcinoma, poorly differentiated carcinoma, or even anaplastic foci in the same tumor. And another evidence is that patients who develop multiple recurrences will show progressive anaplasia with each recurrence, starting off with a well-differentiated carcinoma and eventually leading to poorly differentiated or even anaplastic carcinoma by the time of death. So what do we do surgically? These 85% of the patients no thyroid tissue behind, but it will be a conservative operation. In the intermediate, this risk group with a poorly differentiated carcinoma, prognosis is bad, and you need to do precision surgery, but it will be aggressive precision surgery. And I will expand upon that. And in anaplastic carcinoma, generally it was not a surgical disease until recently, but if the tumor is BRAF V600E positive, there is a role of induction therapy followed by surgery if feasible. So in the well-differentiated, unilateral, intrathyroidal tumors, precision surgery is extracapsular unilateral lobectomy or total thyroidectomy, depending on the extent of bilaterality. In the patient with poorly differentiated carcinoma, you need precision aggressive surgery to achieve complete resection with negative margins. This is crucial if you are going to cure the patient. And as I mentioned, in anaplastic carcinoma, if they are BRAF positive, consider induction treatment with dabrafenib and trametinib, and about 30% of the patients will show shrinkage and make a incurable tumor into a surgically resectable tumor. Now, we are in the era of molecular markers, and there is a tendency to order molecular markers on every patient. There is a defined role for molecular markers, and they serve as an adjunct to guide management of thyroid nodules which have indeterminate cytology, where you do not have a diagnosis of cancer on needle biopsy. And in advanced cancer, the markers may enable targeted treatments of affected signaling pathways. I will not have the time to go through the discussion on the molecular landscape of thyroid cancer, but in briefly, what we have, the alterations in MAPK signaling pathway, PI3K, AKT, gene translocations, gene amplifications, epigenetic regulation, and the progressive oncogenesis model that I discussed with you. That model from follicular cell to papillary carcinoma or follicular carcinoma will have molecular markers. Those which differentiate into papillary histology will be BRAF V600E positive, and those who differentiate into follicular pathology will have RAS, PI3K, or PTEN markers positive. And the poorly differentiated carcinoma will have any or all of these positive depending on the predominance of differentiation of the follicular cell. A number of commercial tests are available: Afirma, Thigen, Thigen Next, ThyroSeq, etc. But in the bottom line is, what do you do, particularly in advanced cancer, if the molecular markers are positive? If the tumor is BRAF positive, then you may want to use lenvatinib, dabrafenib, or trametinib. All of them are BRAF inhibitors. For NRAS, lenvatinib, and for ALK expression, crizotinib are the currently available drugs. When does treatment failure occur? Treatment failure occurs only in patients with gross extrathyroid extension, nearly 50% local recurrence rate, 40% risk of nodal metastasis, and 37% risk of distant metastasis. Remember, I told you anterior extension to strap muscles, posterior extension to trachea, larynx, esophagus, or recurrent nerve. It is here that the surgeon needs to be aggressive. The principle is you must do a complete resection to secure negative margins, preserving vital structures, and using adjuvant treatment, but only after complete surgical excision. If you achieve an R0 resection, you've essentially converted an incurable patient to a 96% 10-year cure. I reiterate this: aggressive surgery with negative margin is crucial in patients with gross extrathyroid extension. If you leave disease behind, expecting adjuvant treatments to work, it will not work, and it will drop down to approximately 60%. So precision surgery is effective ablation of thyroid cancer, leaving no thyroid tissue for remnant ablation.
2 minutes, 2 minutes.
I need about 1.5 minutes. Finally, aesthetic outcomes. There is a lot of noise, particularly from Asia, on remote access operations through the axilla using robotic surgery, MIVAT from Italy through endoscopic surgery, and lately transoral surgery. All of remote access surgery cause excessive tissue trauma and is feasible only for small tumors. Show me a properly done thyroidectomy scar. This patient had a total thyroidectomy. If you place the incision in the right crease at the level of the cricoid cartilage, in a natural skin crease, you will not see the incision. Do a proper closure. Here is a patient with a total thyroidectomy and central compartment node dissection. And here is a patient with total thyroidectomy and bilateral lateral neck dissections. None of these patients had any remote access surgery. So finally, and my last slide, thyroid cancer in 2024 requires precision surgery undertaken after a balanced judgment of tumor and patient factors. Precision surgery achieves complete tumor removal with a curative intent. Precision surgery often avoids the need for adjuvant treatment. Precision surgery is safe and leads to minimal complications. avoids unnecessary tissue trauma, gives excellent cosmetic outcomes. It is curative, and it is a state of the art and science of thyroid cancer treatment today. Thank you.